Hey everyone, we will get started in a couple of more minutes. So just let everyone come in. All right, so I guess we can go ahead and get started. I'm Maureen Winberg. I'm the Clinical Informatics Coordinator here at KU. So I do all of the HERON trainings and pull any HERON data that you may want. So any HERON questions, feel free to contact me with. And then this is Tamara McMahon.
I'm the Director of Engineering and Product Experience. So I help with HERON as well. In the back here, we've got Love. He's the one that helps keep it all going. So, so the three of us can answer questions throughout if there's any issues. He'll be monitoring to make sure everything's moving along smoothly. We also do have some attendees that are attending remotely. So you may hear voices coming out of the speakers. Don't be surprised.
Yep, and then I think Dr. Russ Waitman, he's the Director of Medical Informatics. I think he might be joining us in a little bit as well.
Can you guys hear us okay?
And can everyone on the phone hear us okay?
Yes. Yeah. Yes.
Great. Yeah, feel free to speak up if you have questions or write in the chat box. Tamara will be monitoring that, so we'll try to answer any questions that you have as well. So I just wanted to start with introductions, go around the room. If you could say your name, department, and then your research area of interest. And then if you already have a study population defined. So if you want to start.
I'm Amy Garcia. I'm faculty in the School of Nursing, and my research area is economic value of nursing and patient care.
Hi, my name is Tarun Dale. I'm a second year associate in the medicine department. I started learning about the HERON and started research.
Like us, internal medicine, one of the faculty, quality improvement, and I do a lot of simulation for residents and students. So right now, working on paracentesis and credentialing.
Marcello, doctoral student in dietetics and nutrition. My focus is on nutrition literacy and patient-centered communication.
I'm Jason Springer, I'm a pathologist. I have very interest in research and science.
I'm Marissa Love. I'm a fellow in allergy and immunology. My interest is in food allergy and immunization.
I'm Ashley Small. I'm the research coordinator for ophthalmology, so I just get to help all my residents with their projects.
My name is Sophie Fidel. I'm a postdoctoral fellow in the physical therapy and rehab department, and I'm really interested in how exercise can manage both stroke and Alzheimer's disease. So I would like to learn how to use HERON technology. Danielle Crow, the research coordinator in plastic surgery. Pretty much everyone wants surgery, so I'm sure the rest of them are doing this. My research interests are in medical education and HERON on patients.
I'm Derek Jensen. I'm one of the second-year urology residents. My research interest is whatever my feelings tell me it is, but actually uro-oncology.
I'm Alexander Waldron. I'm a urology clinical research coordinator, and so we do a lot of urology. We're looking at Botox injections and corneal skin.
Kieran Cockerell, I'm a cancer surgeon. My interest is in cancer.
Hi, I'm Steve Simon. I'm actually doing KT, but I work with Russ Waiting part-time on a research grant, and he suggested that I can crash it to just get a little bit of better background in how HERON is used at KU Medicine.
Susan Jackson, I'm faculty here in the speech department. My research area of interest is neurologic speech and language disorders, and specifically aphasia, language problems.
He just talked about me. I'm a local engineer. I help applications built by HERON team to make sure they don't problem.
I'm Wes Whitman.
All right. So here's our agenda for the day. We'll go over how to access HERON, why to use HERON, the Frontiers and Pioneers participant registries, training resources that we have available, how to do some basic searching. We'll review what data we have available in HERON. We'll create cohorts based on examples that you've provided, and then any other examples that you want to create. And then we'll go over how to request identified and de-identified data sets and do hands-on searching. So in order to access HERON, you have to either be a faculty member or be sponsored by a faculty member. So I contacted many of you to make sure that you had your sponsorship in place before the training. So hopefully most everyone can log in. You have to complete your human subjects training, your city training, and then you have to sign our system access agreement. It's only available at KUMC or via the VPN, so you can't access HERON just on your home computer network unless you're logged in through the VPN. So on the right-hand side of HERON, you'll see these 3 login credentials. So in order to log in, you'll need 3 check marks here, either to be faculty or sponsored, have your human subjects training complete, and then sign the system access agreement. And then once you have those 3 check marks, you'll be able to click on the Start HERON search on the left-hand side. And this is the website. So it's heron.kumc.edu/HERON. And we'll go over that again in a minute. So about
one comment, I'm going to interrupt you all the time. We had a great meeting with the health system this month, and we're going to streamline the request process so that in the future, students and staff can initiate the request for sponsorship, and then their faculty will get an email to approve. So we've known that's sometimes been a hiccup for people, and it's going to get better. So they agree to that, and they also agree to a much more streamlined process for allowing basically Maren and our team as honest brokers to approve data requests. So stay tuned, it's going to get even more streamlined.
It will get much better. So HERON combines multiple data sources. We pull data from O2 or Epic, from the billing data, which used to be an IDX, and then various registries. So we've brought in the trauma registry, NCDR, cystic fibrosis, the cancer registry, and others. We de-identify everything that you see in HERON, so we remove all of the 18 HIPAA identifiers, which include patient name, address, MRN. One of the last things that we have to, move that. One of the last things that we do is we do remove, we do date shift, because one of the HIPAA identifiers is anything except for a year, any part of a date except for a year. So everything within one patient is date shifted the same amount up to a year in the past. So you'll see here patient one, these are both patient one. There we go. These are both patient one if their date of birth is 1/1/1950, and then their asthma diagnosis was in 1965. Both of these dates are shifted by -60 days, and then you'll see what date you would see in HERON. For patient number 2, they've got a different date offset, it's -20. So within a patient, it's consistent, but between patients, it's different. So the only things that you really can't use this for is if you're looking at any seasonal changes. So if you're looking, at what happens in the fall, you won't be able to tell because we do date shift up to 365 days. So we don't date shift it to the last fall necessarily. And then also if you're looking at any policy changes. So if a policy went into effect, January 1st, 2017, and you're looking at the date shifted data, you won't be able to tell, what exactly happened on January 1st, 2017. But otherwise, typically the date shifted data you can use just as well.
And
Yeah.
If you need to know the exact dates, you can do a data request with IRB and get the exact dates.
Yep.
It's just that for us to allow you to instantly browse this stuff without having an IRB, that's what.
Yeah.
Are the date timestamps on the lab data or the assessment data also shifted accordingly?
Everything is shifted the same amount. Yep. Yep.
So one
Unless
thing
you
is
get the
shifted, like the time of day will be about the same, right? So if a nursing assessment occurred at 9 a.m., it'll still be at 9 a.m., but it will be shifted back a random number of days.
So, if Microsoft first stroke, and we're looking at 3 months post-stroke, you would have a request.
Nope. You'll know it's 3 months post-stroke,
I
right?
don't know the actual date.
You just won't know the stroke occurred in the fall,
Okay.
of this year. You'll know it roughly occurred at the time zone, if you're interested. But if you needed to know, where probably, in addition to seasonal effect, like if you wanted to detect that healthcare delivery is slightly impaired in the month of July when new house staff arrive, you won't be able to answer that from the identified data. You'd have to go request that. Or if you knew that at this exact moment we turned on a decision support tool in the EMR, or there was a formulary restriction on this day where we took this drug off formulary, it'll look blurred in HERON because it's going to be blurred over time. But you could go back and get our approval to say, I want to get the exact times, and we could give you that data.
So in order to identify a cohort of patients in a unit at the same time, it has to be identified data. Because the times would be off. So if I wanted to know a group of patients with a certain diagnosis on a certain floor.
You could know that because you can do it, and you'll see in the tool, you can search by year, month, whatever, So just think about it. You can search for the year 2015. But what happens is the data in HERON's 2015 will include some people from 2016. And some of the 2015 people in HERON's de-identified copy will now be moved into 2014. So it's healthcare delivery moves slowly. So you're going to see a representative population for a given year. So many people published on de-identified data. But if you said, I exactly have to know that it was this year precisely because of a policy change, then you would want to do your data request for identified data. You could still use the HERON tool to define all your restrictions and timestamps, and our team, when they give you the identified data, will just move that against the real data.
Yeah.
So, do you show a picture of the night heron versus the blue heron?
No.
So that's one thing to point out. So everybody, did you tell them why it's heron?
No.
So
Go ahead.
heron is Jayhawks, right? So we like birds. So when I got here, I was like, let's use a bird that fishes as the mascot. And so we have a bird. The bird that's a heron bird is called blue heron. Everybody knows the big blue heron. He's very public. There's another bird called the night heron. Has anybody seen a night heron before? They're a littler heron, and they're kind of quiet. They hunt at night. So if you look at it, we got EPIC, and we got IDX, and we got the cancer registry. And we take all that data from these various sources, we put it together on a server, and then we build the database for I2D2, this heron tool, and we make an identified copy. So everything is exactly with the real dates, and we can link to the real medical record number of the provider. But then what we do is we then de-identify it to make the DID copy, which is blue heron. And so essentially you're interacting with that copy. But if you ever need us to go back with IRB approval and get the exact dates, or you need the MRNs because you need to do a chart review to go find some data that we don't have loaded, we can do that. Does that make sense? All right.
All right. So why, I don't know where to put this. So why you want to use HERON. So you can get patient counts in HERON, so you can find the number of KUMC patients who meet your inclusion or exclusion criteria, either for grant applications or for feasibility counts. So this is just a query that you could run. So it's looking at ulcerative colitis and patients who are on Humira and infliximab and how many patients there are that would be eligible. So you can just get raw counts. You can also request raw data. So underneath investigator requests, currently the faculty members can request raw data, but then anyone can have access to it as long as they're either a part of the study team. So you can do retrospective studies looking at de-identified data sets and no IRB approvals needed, or you can request identified data like Russ was just saying, and that requires either IRB approval or a QI letter of determination from the IRB. And as long as you have one of those two things, you can get the identified data. You can also do prospective studies. So you can request data on patients in a research study, and that requires IRB approval. So if you've been enrolling into a research study and you want to look at all of their hemoglobin levels, you could send us the patient MRNs, and then we could pull all their hemoglobin levels for your patients in your study. You'd also use it for patient recruitment. So we have the Pioneers Registry, which used to be the Frontiers Registry, and the Pioneers Registry. And so the Frontiers Registry are patients who are at KUMC, seen here, and then Pioneers Registry are patients who are in the community or even outside of the state of Kansas who have agreed to be contacted for research. So you can search for these patients to find patients who are both eligible for your study and then also have agreed to be contacted for research, and then we can give you their names. So we have a number of training resources. In person, we do lunch and learns twice a month. Yeah, go ahead, Russ.
The other thing is, if you have a relationship with a clinical department or division, you can contact them. You don't have to have only the registry patients. So Jason's in the vasculitis clinic, the rheumatology, he already has a treating relationship with all rheumatology patients. So you can use the database to search for your patient population with very precise inclusion criteria to then get all this stuff. So we've supported people both ways.
So the lunch and learns twice a month. If you come and attend from 12 to 1:30, there's free pizza, and we'll answer any of the questions that you have. We also do this yearly workshop, or this time we are doing it twice this year. And then if your department wants a departmental training, we could do a group presentation for you. There's also a number of online training resources. So when you go to the HERON homepage on the left-hand side, that you'll see all of these online training resources. So if you're getting in there and you have questions, you might want to check out the HERON training videos or this HERON training manual. So these
manuals, Maren has done an amazing job. Like other campuses are in India, how much training. And she also wants you to boost her YouTube counts.
Yeah, we're trying to get much higher numbers on YouTube. I don't think we're going to get into the top, 1% of YouTube watch videos. So there's the website for all of our training materials. It's on the KUMC website under medical informatics. And then there's our YouTube channel, so you can definitely watch those. And then also within HERON, you'll see there's a couple of help buttons. So there's a help button here, and then there's also HERON help in the upper right. So it's time to start searching.
How many people in the room have access to HERON before? Has anybody logged in?
Yeah, it's a number of people. All right, so here is the HERON homepage, and if you guys want to pull it up, go ahead, and it is heron.kumc.edu/HERON. Like I said, if you get to that page, you can look over here on the right-hand side and you'll see the login credentials. So in order to be able to search, you'll see that you'll need 3 check marks. So if you have those 3 check marks, you can go ahead and click Start HERON Search.
And there's also a link down on the bottom there, here and in the HERON page that says Write Praise. So if you're stuck, if something looks broken, just click the button and it'll launch a RateCap survey and it'll go to the team to look into your problem. Or if you're really happy, like it's been great for you and you want to make people feel good, you can send them a praise.
That would be great. Yeah, so the button is down here on the right-hand side. So click on Start HERON Search. So it does happen occasionally where HERON will go down. So if it is down, go ahead and click on it so then we know, and the amazing Love Patel will bring it back up and magically make it work again. So definitely let us know. Yeah, it's taking a while for my computer too. It sometimes just takes some time, especially when there's large numbers of people trying to get into it and search at the same time. It often goes a little bit slower. So when you log in at the top, it says what project. So right now we're on HERON Calamus, and the data is through January 2018. So we try to release new data about once a month, and all the releases are named after lakes in the area. I can't remember where Calamus is, if it's up in Nebraska or Iowa.
We originally had it all lakes and rivers in Kansas, and then we were running out of lakes and rivers because we collaborated with other campuses. We added state outreach.
So in the upper left, these are all of the data that you can search on, so all of the different terms that you can search on. The middle is a workplace. You're going to see one folder with your username and then a shared folder. So only you and then our team have access to your personal folder, and then the shared folder, you can put queries in to share amongst your colleagues. The bottom left, you're going to see previous queries. So you'll see all the previous queries that you'll only see the ones that you've run. We'll be able to see all of the queries, so if you ever get stuck and you want to just send me your query name, I can just pull it up and look at it. So this button is my favorite. It's Resize Workspace. It's like 3 windows, and you can click on it and expand it. I should have asked, did anyone have problems besides it being slow? Was everyone able to pull up HERON, or did anyone get stuck? No. So this is the data we have available. We have the alerts. That includes like best practice advisory alerts, so like medication alerts that might pop up for clinicians. We have allergy information.
So Ellen, we can look at things like MAR alerts for nurses. Like Jordan.com.
We have allergies. We have the cancer cases from the cancer registry. We have both the layperson hierarchy, which is kind of a condensed version, and then we have the NACER hierarchy, which is the full version of the cancer registry. We have cardiology lab results. So probably the biggest thing I see people looking for in here is echocardiograms and ejection fractions. We have the cardiovascular registry, cystic fibrosis registry, demographics. So that includes age, ethnicity, gender, race, religion, vital status.
It's got a couple things if you're doing prospective recruitment that can be really valuable, like does the person have an email address or do they use MyChart? So if you're thinking of outreaching to patients electronically, that can be useful. And it could also be useful if you're doing a prospective survey of patients to know, hey, she may be computer literate because she uses my chart or uses email.
Yep. And then we've got diagnoses, which are listed by ICD-9 and ICD-10 codes.
Are those the post-diagnoses or working diagnoses?
So if you look at that, that's a good question. Open up the folder of diagnoses.
Mm-hmm.
What you'll see here are billing diagnoses. So the modifiers, when you look at here and you can bring over these concepts, and then it has this concept called a modifier, which says this fact, this diagnosis code 250, was it assigned in the billing system? Was it assigned by the physician? Where did it come from? So those modifiers let you know where it comes from. So you could say, I'm only interested in diagnoses that were billed coming out of either the IDX system or UHC or hospital billing data. I don't know if people are billing czars, but basically there's a thing called a professional charge where the physician providing professional services will bill for things. And then there's a technical charge of the facility, which would be the hospital charge. The clinical data would be, it's documented in the EMR from a clinical perspective, and it was assigned as part of the encounter on a problem list. And then I think we have some other modifiers like is the problem resolved, for example. Some of those are spotty. Physicians often assign them, but they don't oftentimes will indicate explicitly that the problem is resolved. So buyer beware a little bit, but you can triangulate on things according to how was this diagnosis assigned. Does that get to your question?
And to be safe, would you just throw them all in then? Like,
well, she'll show you. You typically, if you don't want to get into choosing, you can just say, bring the whole thing in, right? And you can say, I don't care how it was assigned, I want to know they've got diabetes. Okay. And then if you then, though, depending on what you're trying to do, you could get more refined if you wanted to. So if you're thinking about sensitivity and specificity, where you say, I want to know it's doubly confirmed that both it was on the physician's problem list as well as it was coded, you can use it to say, I want this and this to be true. Okay. So it's kind of when you're casting your net, you know, different types of researchers may come from a different perspective. So they may say, I'm used to using validated billing data. So they may say, I'm only interested in billing data. So in one sense, HERON gives you the tyranny of choice, where we do have that ability to show you more choices than you're used to. In many cases, most people probably don't bother worrying about the modifiers. They just want to know, was there a diagnosis code assigned?
Yeah, that's typically. We've also got flow sheet information, so all of the nursing documentation, physical therapy, occupational therapy, that's all within this flow sheet folder. We have history, which includes family history diagnoses, social history, so this is where you'll find tobacco usage. A lot of people are interested in if people have smoked, so you'll find that in there, and then also surgical history. We have lab tests organized by both the KUH hierarchy and then LINC, which is a national standard. I tell most people here to just use the KUH hierarchy. The items should be in both folders. We have medication data, and we'll go through how to actually find all of these things in a minute. We've got microbiology results, things that have been ordered, procedures that have been done. That's by CPT code, ICD-9, ICD-10, and now HCPCS. We've got red cap projects you can bring in. So if you have a red cap project with patients in it or data that you want to link up to the HERON data, we can bring that in for you, and then you can search both your red cap data and the HERON data at the same time.
Does anybody do any work like that in their group, where they might have a red cap project they've been managing for a long time in a very specific cohort? We can load that every month in with the rest of HERON, so you could say, I'm going to use my red cap project like a fishing net to tag the people I'm interested in, and then I want to use HERON to kind of grab all their BMI changes or lab changes.
We have research studies that the patients are enrolled in, specimens that have been collected, the trauma registry. Visit details. This is where you'll find actual information about what departments they went to, both from IDX and NO2, their discharge disposition codes, what kind of encounter was it? Was it an ambulatory visit, an inpatient hospital stay? And then we also have place of service, and then visit vitals if you were interested in looking at height or weight or a BMI.
And those are kind of bread and butter vitals that are recorded in Epic. Up under the flow sheets, you would find very specific vital signs. So these are kind of standard vitals that Epic represents on most ambulatory inpatient stay. But if you were looking like for central venous pressure from an ICU setting, that would be in the flow sheets up above. The other key thing to keep in mind that's in this folder is age at visit. When you're looking at age up in demographics, that's going to be how old is the patient now. But you may want to use the age at visit feature where you may be interested in a cohort of people where, for example, you're interested in toddlers who were seen, in an inpatient setting at that visit. So you want to know who was less than 4 years old during a specific visit as opposed to who is less than 4 years old right now.
And then we have visit notes, so we're working to de-identify all of the free text notes and bring them into HERON. They're not all de-identified at this point, but in the
There's
next...
a couple things to point out here. So one will be, this should be next release. You'll be able to search all physician notes and other types of notes with the free text. The other element, what is called note concepts, is has anybody used Note Writer before in Epic to write a note where you pick concepts? Those Note Writer concepts we largely have brought in discreetly. So if you look at Epic concepts, we have over 117 million facts where, maybe doing a history physical, people said the ears are normal. So that's discrete data from the notes where the Note Writer is used that's available for you to build a query on. That hasn't been exploited as much as we don't advertise it as much, but we'd love to have projects where people are using that data.
And then the last folder down here is Vizient, or it used to be called UHC, University Health System Consortium, and that's inpatient quality data. So you can find the hospital length of stay here. There's days to readmit. We have the insurance for the inpatients. We currently don't have the insurance loaded for outpatients, but we do have the primary payer and secondary payer here if they've been inpatient.
Another thing is if you're a billing wonk, there's a thing called the DRG. So what was the main diagnostic related group to the admission? That data is coded in there by MSDRG as well as APDRG. So you can use those to define a cohort. And some of the measures in there are pretty cool because these HRQ quality measures and other Joint Commission core measures will define metrics for study inclusion. So if you want, it's another way to define a population. So they may have defined a very standardized way to say who is hemorrhagic stroke, and you can use the HRQ definition across UHC studies.
So is that DRG data cross-mapped up to the diagnosis?
Everything is matched, yeah. So you could say, I'm looking at a hip replacement DRG, and I want to see, did the patient also have a diagnosis of COPD or something? So, as well as the discharge status, as well as all the other observations.
All right, so if we just want to do a basic search, we can go into demographics. And I used to work at the Children's Hospital, so we'll do a search to see how many pediatric patients there are. So you open up the folder and then you click and you just drag it over. And if we wanted to do, say, 0 to 12, you can open up any of these folders and get more specific. So you can either pull them over at the folder level, like I did for 0 to 9 years old, or for the 10 to 17, you can pull over the 10 years old, 11 years old, and 12 years old. So you always have that choice in HERON. When we get into the diagnoses, you'll see the same thing. You can pull it over from a lower level or from a higher level folder. And then you click Run Query, and number of patients should automatically be checked, and leave that checked. And then up here in this bar, it says please type a name for the query. So you can say 0 to 12 years old, and you can click OK, and then it will run. Down here you'll see how long the query's been running for. So right now it's been 5.7 seconds, and it always spits out the number right here. So it's about 84,000 patients are currently 0 to 12 years of age. So everything within a group is or, so it's saying are they 0 to 9 or 10 years old or 11 years old or 12 years old. Now, if I wanted to look at how many of those are female, I can open up gender and pull over female, and I'll put that into group 2 because things between groups are and. So now it's 0 to 12 and female, and you can click Run Query, and it does auto name it, so you can let it auto name and click OK.
So this is age today. So if the record was from 2015, a 1-year-old would be 4 today.
Mm-hmm.
Yeah, exactly that point. So when we're running queries in our study, our exclusion criteria in our study is patients less than 18 at the time of surgery or whatever it is. I mean, is there a way to exclude that?
Yeah, so that's what Russ was saying with the age at visit. So we can look at people who are, over 18 at the time of the
This is
visit.
kind of like you're saying, generally right now, how many people are under 18? You do it this way. If you wanted to say how many people 32 to 40 years old had a hip replacement, you would go down to where that age of visit was, you'd use that age, and then you would say, pull in the hip replacement procedure, and then there's a feature.
Yeah, you're jumping ahead, Russ.
There's a feature to let you do that calculation, and she'll show that to you.
Yeah, let's do a couple more basic searches, and then we'll do the age of visit. Yeah.
So when you pull age of visit, what is it using your current age, like at this point in time? Because like age of visit could be, the parent has seen for 2 years. Is it going to use their last visit?
It calculates an age for every single visit that happens. So every visit, there will be an age for that visit.
So when it excludes people, would it just exclude the visits for that which they were under 18?
Okay, so let's take a look at it. So
you can't get away.
I know. We'll look at it. So we'll go to, I'm just going to go to diagnoses, and say we're looking at diabetes. That's ICD-9 250. And so this is what the diagnosis folder looks like. It is, I can go to ICD-9, and then it's just numerical, so it's really easy to navigate. I often tell people to Google for a diagnosis code, and it will get you in the right ballpark, but it won't necessarily get you the right code. So then you can navigate to where Google tells you to go, and it might be right, say it's 250, or it might be something more specific or more general. So look in the hierarchy and see exactly what you want to pull over. But I'm going to go ahead and pull over diabetes, and I'll pull over the whole folder. And that, I think when we were talking about the modifiers earlier, this is typically what happens when you pull over the folder. You're just including all the modifiers that would be associated with that. What do you say? How did I get there?
Yeah.
I clicked on diagnoses, and then ICD-9. Yep. And then I scrolled down. And then I scrolled down to 240 to 279, and then you'll find 250. So I just kept going through those folders. Yeah, go ahead.
We're doing ICD-9 and 10 just to catch all.
That's what I was just going to say. So you'll want to do both the ICD-9 and ICD-10 to catch everyone who's had diabetes. So we can then go up to ICD-10, and it's E08 to E13. So we could either navigate through it, and if you've used a code from Google, I definitely say to navigate to it. Otherwise, you can use this find and search by codes, and you can select a coding system, and you can select ICD-10, and you can type in E08 to E13 and click find, and you can drag that over. So only do that if you are confident in the code. And then you can hit run query, and we'll just get an idea of how many patients have diabetes. And then we'll go ahead and add the age of visit.
So we'll geek out here 1 second.
Yep, go ahead.
So anybody who's clinical has to deal with diagnosis codes in the assignment, right? Okay, so it's been a big pain in the tuchus. So what happened is everybody had to move from 9 to 10 for their payment. And so HERON shows you both trees, because a lot of times researchers are used to looking at ICD-9 codes in terms of how they define computable phenotypes. So what happens under the covers is, if the bill was generated out of the billing systems like IDX or Epic now is doing the billing, it will assign an explicit code to say this is ICD-9 or this is ICD-10. And we'll take that explicit code and we'll make it browsable via the 9 or the 10 tree. Are you with me? So that's why you need to look at both. But if the data are assigned in the Epic EMR as a clinical diagnosis, Epic internally assigns something called a DXID, and you'll notice if you use Epic, it lets you choose what's called an interface terminology that's clinician friendly, so you might just say AMI or stroke, and it's going to internally map that to either 9 or 10. So when you're browsing the diagnosis trees, you'll notice they're both pretty big. So all these diagnoses that are assigned an EPIC as a DX ID, they'll roll up to either tree for the most part. So does that make sense at all to folks? So that's it's kind of one of those questions. You can get a pretty good sense using either the 9 or the 10 tree, depending on what time you're looking at. But if you want to be complete, you want to grab both terminologies to get all the billing codes for both.
Yeah, and you can see what Russ is talking about. After every term, we have brackets and we have facts and we have the number of patients. So you can see this is the ICD-9, we have 92,000 patients, and then the ICD-10, we have just about 80,000 patients. And so the patients are distinct number of patients who've had that diagnosis recorded. And then the number of facts are how many times it has been recorded for those patients. So clearly it's been recorded multiple times for many of the patients. So whether that's on the problem list as a diagnosis code for the like clinic visit, and then also just like maybe multiple clinic visits, it was tagged as the diagnosis code. Yeah.
It should be separate, so nobody can say like that these might be patients that are counted twice between the 80 and the 92.
Yeah, so they might be in both of these folders, but when you run it, these number of patients, those are distinct patients. Yep.
Yeah, and one other thing to point out we glossed over is when you first logged into HERON, you may have seen a splash screen celebrating Calamus and all the new features. And that's available as a blog wiki page on our website. And it will tell you on that wiki, if you read it, how long ago did we first start getting that type of data. So that's a key reference, because each of these systems we get data from has kind of a lifespan, where Epic came along in November of 2007, and IDX was available since 2000, and UHC is only available since 2008. So use the system, and then if you're going back and trying to get really precise about a population, you may want to reference, well, what real steady time period can I look at this cohort across? For example, the cancer registry goes all the way back to the 50s, so we've got some, in some cases you may have a very longitudinal view, in other cases it may be more short.
Okay, so we've got our diabetes here. Oops. And then we wanted to look at the age at visit. So if we go down to visit details, you'll see the age at visit. And there's 0 to 9, 10 to 17, and then all of these other ones. So maybe we'll do 18 to 34 and 35 to 44 years of age. Now, if I run this, there's this temporal constraint, and right now they're treated independently. So it's saying at any time a patient had a diagnosis of diabetes recorded, and at any time they had an age at visit between these ages 18 to 44. So I have to switch this to saying selected groups occur in the same financial encounter to say that they had the age at visit, the 18 to 44 years age at visit at the same time that they had the diagnosis of diabetes recorded. Does that make sense? And then we can hit run query and see how many. So that's just a trick you have to know to put the age at visit in the same encounter.
Because otherwise, HERON's just, every time it sees something about a patient, it logs one of these age at visit criteria, which is why there's so many millions facts. So if you don't, it's the powerful feature where you're trying to say, I want to know that they were this old at the same encounter where a diagnosis code was assigned, or they were admitted. And you can also use same financial encounter, very powerful, not using age, where you want to know, I want to know who had a procedure done during an admission, or who had this diagnosis code and this diagnosis code both assigned at the same time.
Yeah.
Can you go over this one more time? Can you go over it one more time?
Oh, why you need to do that?
Like how do you got this point? Like I guess the initial part.
Okay, how we got this? So we went in
Age one, the age, this one, yeah.
the age at visit. It's in the visit details, and then age at visit. And then I pulled over those two folders, and it was important I put it in group 2 because now it's saying and. Did you find it? And then do you see the temporal constraint? This is a drop down, and you'll want to switch that to say selected groups occur in the same financial encounter to say that those two things are happening at the same time.
And not to get too advanced, but you can, when you're in that mode, you can also toggle any other groups independent during the same thing. So you may have some facts you want to treat independently, or other things you want to make sure they happen in the same encounter.
Was that 18, 34, and 35 and 44? That was just to catch everyone 18 to 44. Did I miss something there too? Okay.
That was just 18 to 44. I just wanted to run a smaller
Sure.
group than, everyone over 18. So like Russ just said, so that you have an example to put to it, if you wanted to look at people who've been in the hospital, whenever you pull over anything that has numbers associated with it, so the length of stay is how many days they were in the hospital, it lets you choose if you want to do less than a certain value, so people who've been in the hospital less than 5 days, or you could do greater than 5 days, or you can just say no value. So I'm going to choose no value and say okay. And so I could run these all in the same encounter, saying that they have to have been in the hospital when they were 18 to 44 and had a diagnosis of diabetes recorded. Or I could say, you know what, I can treat this third group. You see where it has this toggle right here? I can treat this independently. And so it's saying that they have to have had at some point ICD-9 or ICD-10 code for diabetes at the time of the visit for 18 to 44 years of age. And then at any other time they could have the hospital length of stay. So they wouldn't necessarily have to be 18 to 44 at the time of the hospital length of stay. That makes sense?
On the temporal constraints, go up to the temporal constraints, there's a choice of defined sequence of events. Does that set you up for repeated measures?
Well, we're not leaving the beginning workshop.
Yeah.
It's a powerful feature where you can define events and say you want to look that this event happened before this event happened, and you can change it. So a classic example could be you want to look at people who had a normal creatinine function, who then were exposed to a nephrotoxic drug and then developed impaired renal function. So you could use defined temporal events to look at that type of, you define your population you're studying, and then you define which events, and then you sequence the events. That may be for our advanced class.
That's for our advanced class. We'll see.
Hang out all day. We'll figure
Okay, so I had kind of looked through different examples that people had submitted that they were interested in, and Sophie, right? I looked at yours and I tried to build it, so maybe we can go through that example.
Before you move on with this.
Yeah.
Okay, this was a common one that people sometimes mess up. That's why whenever we're talking about having things in the same encounter, there are some things that you're never going to have in the same encounter, and that's your demographic information, such as gender, vital status, because that gender may not have been recorded at that encounter that you're interested in. I mean, it's actually more tied to that person's birthday than their first visit date, I believe. So there are, when you're creating queries, and if you're going to use things like gender or a lot of stuff in the demographic, you're not going to want that in the same financial encounter.
Does that make sense?
Because it could limit your search to zero.
Demographics. Also, like another good example she's bringing up here is vital status. If she goes there, what you'll see is we know who is dead according to the hospital and who's dead according to Social Security. So that Social Security death information can't be linked to a financial encounter. So if you were building a query like she had before, and then you wanted to say how many of those people are dead, you'd include that in a final conjunction, but you wouldn't make it some financial encounter because it doesn't make any sense, right?
You get zero patients.
You get zero patients. The other example would be you may want to define, there's a feature called exclude, where you can basically take something and you can say, I want to exclude all the dead people. And so you wouldn't make that same financial encounter.
Yeah, so we can exclude the people who've passed away here. And so under vital status, this is what Russ is saying. This folder is the deceased from 02. So you'll pull over the whole folder for deceased per 02. And then here's deceased per the Social Security Administration. So you want to make sure that you grab both. And then, like Tamara said, you want to treat this group independently. So you use this toggle here, and you treat it independently. And then here's the exclude button. And you can click on exclude, and then you'll see it says none of these. So you can do that if you're looking at people over 18, and you don't care if you want them currently over 18. You could throw in the like 0 to 17 in here and exclude that as well. Yep, go ahead.
So if somebody dies during their treatment in the hospital, are they logged as deceased, or are they discharged to the morgue, or how is that received?
I think it's if they die in the hospital. I think
It
it's
would be
under.
deceased, according to the hospital. So you have it up there. You would also have it, hopefully if they have a social security number, they'd be dead there. And then they'd also be dead down here under discharge status. I think they're expired.
Okay, is it expired? So this is under, yeah, here, expired all in-hospital deaths except for Medicare or Champa's hospice patients. So,
Okay, thank you.
Welcome.
In group 3, what is that top folder include the one below it?
It does not. So this top folder includes this deceased death date unknown.
Okay.
That's a common, that's why I said you want to make sure that you grab both. It's a little, I guess it's a little bit confusing how we have it organized there. We should maybe say that this is deceased per 02 because that's really what this folder is, and then this is deceased from the SSA. No, that's okay. It would make sense that this deceased folder includes all deceased, but it doesn't. So
There's one thing we'd like to do if we get around to it. Notice we got 2 million people, 2.3 million people. But if you notice here, we don't know vital status on a whole bunch of them. So we've got a master patient index of like everybody's seen here since the 80s or 70s. But a lot of those records, we have no other data on them. So we actually have somewhere on a file, we have old hospital billing records that we might link in. Just keep that in mind. In some cases we've got a lot of data, but in other cases you can look at some of these and see there's a fair number at the biggest level where we really don't have much information on.
okay. So the example that you wrote, Sophie, was that you wanted to look at arterial stiffness and cerebrovascular disease. Is that right? Okay. And I don't know, I looked up arterial stiffness and saw that atherosclerosis might be a diagnosis for that.
Do they have different ones?
So I don't know exactly what you wanted to include, and we can look up any, ICD-9 or ICD-10 code. But I did look up atherosclerosis, and it looks like ICD-9 code is 440. So we could pull that over. Diseases of the circulatory system.
While she's keep building, I'll comment. You can find things by these folders, but there's also a find tab up there where you can search by name, or if you know the exact code, you can search by the exact code.
Yep.
You're probably going to cover that at one time.
I showed it earlier, but I can show it again, the search by codes.
Did I miss that?
I think you were drawing.
Oh, you're right.
So you can do for the ICD-10, I looked up and I saw I-70, so you could find and search by codes like that. And so I always recommend that people run it as they build it so that you get an idea of how many patients you have and see if it makes sense. And then you'll also see how your numbers change as you add to it. So 14,941. If you wanted to then look at cerebrovascular disease, it looked like there was a whole folder for it. So it looked like it was 430 to 438.99, and you'd want to make sure that you put that in group 2 so that it's and then you could also look at the ICD-10 code for cerebrovascular disease, which was I-60 to I-69, and you could run that. So 6,321 patients, it looks like, have atherosclerosis and cerebrovascular disease. And if you had other ways to define arterial stiffness, you could also put those into group 1, to say atherosclerosis or any other ways that you'd want to define arterial stiffness.
Quick question.
Yeah.
So one of the things that could be arterial stiffness is pulse pressure, so systolic, both pulmonary and diastolic.
Mm-hmm.
So I saw that there's blood pressure. Is there a way to create, like, how do you get the data? Like, how does it output? Like, where, like, is there an Excel where you would be able to create a new variable?
Yeah, you can get it in a raw CSV file, and then you would have all of those facts about the systolic and diastolic pressures, and then you could, then you could look it up.
Are you gonna cover the data delivery?
Yeah.
Some like the diagnosis that they're getting, these encounters we brought up,
Mhm.
how they were sort of given to the patient, is it through episode 2 or is it like physician dependent? 'Cause I know we get prompted a lot to click on all the boxes on the problem list, and we're not really good about doing that all the time. So just trying to figure out how many patients might be missed due to, or how they get these diagnoses on.
Yeah, so it's whatever the clinicians
It's
enter.
like we were saying, it's always, so you could be in O2 and putting it on the problem list, but then you may forget and you get prompted when you order a lab test in your diagnosis code. Both of those will make it in. Some will be tagged with a modifier saying it was entered on the problem list. Some would say it's part of the hospital encounter, but then also the billing coders will code everything. So they'll review the whole chart and then code the data. So that's where you can look at it always. And you can actually do some work where, if you wanted to say, I want to know where both the problem list and the coders said it was this during the same encounter, you can actually run little experiments to say, how consistently do physicians and coders explicitly assign the same diagnosis code?
You can also search by date. So earlier, I think, Amy, you were interested in searching by dates. So, if you wanted to look at a certain date range, you can click on this date range underneath group 1, and you can limit this. Maybe we want to look at people who've been diagnosed with atherosclerosis after 1/1/2012. And then if you don't check 2, it will just go through the end of the data. So you can look at that. And if you want it on both groups, you're going to have to put it on both groups. It doesn't automatically carry throughout the groups. You can do it for every single group. So we could also put group 2, 1/1/2012, and hit OK and click run. And then we can see.
Could you do a run query as well? What's the other two boxes that are there?
Yep.
That's the default. What is patient?
Yep, so you can check patient list.
We charge you money for these extra clicks.
No, we don't. So I'm just going to give it a name because I am saving the patient list. And the patient list will allow us to use these analysis tools. So we have a demographics plugin. And so it basically saves all of these patient numbers, these 3,926 patient numbers in a table behind HERON. And so when I look at my previous queries, you'll see all the previous queries down here. And I could open up atherosclerosis. And in the results, you'll see that there's a patient set saved. So I can
previously we'll just have results.
Yep. So if I look at this, you can see that there's only just number of patients. So if I go to analysis tools, I can click on demographics, and it says drop a small patient set. So I can drop this patient set and click view results.
So if you give it like a big set, like all people over the age, it'll be really slow because it's shipping around a lot of data. But for small cohorts, and this is actually a pretty good one, it runs pretty quick.
Yep.
Oh, things are going really good. Great job.
I know, don't jinx it.
But it lets you get a high-level profile of the demographics of this patient population.
Yep. So you can see the age ranges, slightly more males than females, race, language, marital status, and religion. Oh, how I got here? Yeah. So if I'm just going to click Find Patients because that goes back to the query. I click on Analysis Tools. There's a drop down next to it. You see that arrow? Click on that, and then click on Demographics 1 Patient Set. And then it says Specify Data, drop a small patient set here. And I opened up my previous query, and I opened up the results of it. So it was closed like this. I opened it up, and I opened up the results. And then I can drag over the patient set. So I had to make sure that when I hit run query, I had to save the patient set. Did you do that? Yeah. Okay. Did you get it to work? Okay.
What's the timeline?
Yep. Okay, I'll do that now. Yep. No, that's okay. How did I save it? So I clicked run query, and then I chose the patient. You see how that patient list is now checked?
Okay. So out of the box, don't always keep it checked because you're going to make a whole bunch of tables. But use it judiciously, and they're cool too, because if you ever built like an ultra complicated query, you can build a query and reuse the patient set as if it's a conjunction in your query. So if you have like a really complex definition for a population and you want to save those 3,000 people, you you can save that set. And we'll preserve it for how many months?
3 months.
We keep them around for 3 months. So we'll keep them forever, but for 3 months, we'll keep that set around. So it can also be useful as a shortcut to define a query.
So what Russ is saying is you can open up this previous query and drag up this patient set and put it into group 1. Hey, Dan. And then in group 2, you can put something else that you're interested in. So if you're interested in looking at, you know, how many of those did we exclude deceased? I can't remember. What?
I don't think so.
Okay, so we could look at how many of those patients have passed away. And it should run faster because you've saved the patient set. So it's already got those 3,000 patients, so it's not doing as many ands. But I ask that when you're about to submit a query, that you never submit a query with a patient list in it because we can't run it as easily. So really, if you're building your query, you should not be using the patient list. It's only if you want to be fancy and run a couple of things quickly. What? Oh, when you click on Run Query, do you see how there's these check marks that you can add? So you want to check that patient list. Did you check that? Okay, and then hit OK. So I'm going to go ahead and I'm going to pull back up my atherosclerosis. Wow, people are running a lot of queries. This is great. So I'm going to pull up the atherosclerosis. So to pull up an old query, if you haven't done this yet, you'll want to click on it and then drag it up, and you want to make sure that you drop it where it says query name. And then you'll see it populate with all the terms that we had in there. So to get to your timeline question,
Let's do something fun like length of stay.
That's what I was going to do. Yeah. So I was going to go to length of stay and add in hospital length of stay. And this time you can make it search for, you know, greater than 3 days so that we only look at patients who've had atherosclerosis and cerebrovascular disease and a hospital length of stay more than 3 days. If I click Run Query, then I'll do the timeline.
Wait, let's stop. Cancel. Let's make it maybe a little. You want to know they had the cerebrovascular disease during the same financial encounter as a hospital length of stay, but maybe the atherosclerosis is independent. That could have been recorded in a clinic setting. So that might be a realistic example of something you might want to do.
Everybody follow that?
So I was just saying, I'm trying to think of a, you know, maybe they had a cerebrovascular incident and you're capturing everything. It's a very broad class of diagnosis codes. You want to know they had that diagnosis code assigned during the time they were admitted to the hospital and they were there for more than 3 days. So that's why we're using the same financial encounter. But maybe her hypothesis is they don't have to have documented the stiffening of the blood vessel during that hospitalization because the clinical team may not have been thinking in the crisis about do they have atherosclerosis. But if that diagnosis code was assigned at a previous clinic visit or a subsequent clinic visit, you want to count those people. It'll still pick them up if they had it during the hospitalization, but I may not want to require it had to be documented during the hospitalization.
So in order to make that not be required to be documented during the hospitalization, you'll go to Group 1 and click on this drop-down menu, and you'll say Treat Independently. So this is where you can have the mix. So this one's treated independently, and then these two are at the same encounter. And then we'll click the Run Query, and this is where you can check the timeline. So now all of ours are checked, and you can hit OK. You don't have to have the patient list checked to run the timeline. It will automatically save a patient list. Do you have a question?
Where are the saved queries at?
Oh, they're in the bottom, the saved queries. They're down here under previous queries. Do you see it?
If you had your left window opened up all the way, you don't realize.
Yeah, so you'll want to unresize. Sorry, I hit the resize and unresize all the time. So
we keep their queries around for how long unless they pay you extra money?
Forever, I thought.
We keep them forever, so you get your queries
And
forever.
yeah, so if you don't see all of your queries, like right now, since I see everyone's queries, everyone is filling up my queue. So you can click on this button that has the green check mark. It says Show Options, and you can increase it. So if you feel like you're not seeing all your queries, just increase it to 200, and then you can hit OK. And now I'm going to see the last 200 queries here. So you can do the same thing. You can increase it.
Could you take this that you're working on and sort it down to patients who have surgery, any surgical procedure?
Sure.
Where do you look? Is that in the billing code?
That would be.
You can do this great thing. You can right click and you can refresh all, and that's going to close all your folders. So when you're in deep down, you can close them all. So you can look under procedures. You'll find surgeries under here. CPT codes, right? Surgery. And then you could also look under.
Well, and within there, in that folder, it may be if the procedure was done as an inpatient encounter and billed as an inpatient ICD 9 or 10, it'll be in that as well. So those are going to be other types of surgical procedures. And then the final place that people don't check very often is the past surgical history is not very well coded in Epic, but it is another place where you can pick up on a high level fact that the patient had a past surgical history.
So here's surgical history. So here is the timeline. So is that really hard to see? Or can you see it okay? Okay. So you'll see it graphs when they had all these facts recorded. So this is one patient, and then this next box is the next patient, and so on. So this is their de-identified patient number. It is not their MRN. This is their gender, and then how old they are, and their race. And then these are the different facts that we'd pulled into our query. It displays those facts. So we have the cerebrovascular disease, and each of these tick marks is when it was recorded in the medical record. So I can click on it, and you'll see this event ID. It's like what encounter it was. So every encounter will have an encounter ID or an event ID, and then it has their patient ID, the concept ID. So this is what Russ described earlier, the DX ID. This is the actual number that it was coded as, and then the start date and the end date, and then what the modifier is. So this was the modifier is the medical history. So you can zoom in using these plus and then minus to zoom out, and then use the pan to scroll left and right. So if I scroll left, now I can see, you can also see the diagnosis for atherosclerosis and all of the times that it was recorded. These longer bars indicate kind of like a start and end date. So this looks like it has a longer range, I guess. So this one the start date was 3/29/2013, and then somebody marked it as ending on 9/11/2014, and that was on the problem list. You can also see the hospital length of stays.
And if you hover on that hospital length of stay, it'll show you how many days long.
If I hover?
Yeah.
I think you have to click it, and then it says in the NVAL num, it's 6 days.
And you'll notice it has a little bit longer bar, so you can zoom way down and see that length of stay in high detail.
Yeah, and so you can then see that, like, visually, like this one looks like it's a little bit shorter than the second one. So this one's 8 days.
So I love the timeline when I'm solving a problem. I'm trying to figure out what's going on, because what you can do is she can go back to specified data. Go back to the analysis tool, go back to the timeline. This is what's really powerful. You got your timeline. Oh, shoot, you lost me.
Oh, sorry.
If you got it still open, don't close it all the way out. What's really powerful is once it's built with the stuff you built your query on, you can toggle back to specified data, and then you can drag anything over from the left menu to be plotted as well. So you might have said, I'm doing this hospital length of stay study, and then I could drag in what was the APDRG. So you could visualize, what types of diagnosis, main diagnostic reasons are they coming to the hospital. You can drag in things like provider specialty or clinic location, because you may be interested to see, let me see visually how many people wound up being discharged, and then they had a follow-up visit with cardiology. So it's a nice, it sometimes could be slow because you're asking the computer to do a lot, but it's very powerful to have a definition of your population and then drag in the things you want to plot to kind of see how many of your patient population has that factor.
You have to run the query back over, so you have.
No, I clicked out.
Yeah, you could run it again. I'm going to mute it down real quick. But yeah, that's.
I'll show you. Yeah, you've got to click back in this analysis tools in the timeline, and then you can add extra things. So.
Let's see if finish up here. Let's see if we'll give it a second. Hopefully it won't be too slow.
I just always thought that you guys had a group 4 and had all the different parameters that are part of your inclusion exclusion criteria.
You
can do that. What you're doing is actually very cool too. You can put everything in a final group that really doesn't define your population, and we call that the shopping cart of everything you want data on. And that's a good way to do it, and it's actually good to do what you described, which is keeping it in a query because then it's reusable. But if you're kind of free-form thinking here, you can just visually explore your data right now, and she can be right there and say specify, whoops, don't do that.
Oh, how to,
Now go specify data, and now let's
I
drag
should do
in
this.
something else. So go down to the Visium data,
okay,
maybe,
sure.
and bring in, under visit details, the physician specialty.
Okay.
Just drag,
Oh, the
drag
whole
the whole
folder.
thing in, and drag in the discharge status. And see now when she plots this, she's going to see that type of data. She can hover over it or tick and see kind of what's happening with these people. Does that make sense?
Would that save that then under your query or?
No. That's the
No.
only downside of doing this is if you find out something really cool, you're like, ah, I got to go back and note it or put it in the query. So what you're saying is actually a very good way to do it too. Just keep in mind if the final things you're adding in that cart, they're also restricting your population, right? So you would almost want to do that and include something that's going to encompass all of your patient population.
Yeah. Yeah, I actually like it the way that you described better. That's what I would probably do, but Russ uses the timeline more than I do,
Well,
so
I'm
it's a
saying
good way.
because it is a tool right there in the tool you can use. So.
Yep, so now you see those things plotted as well, the physician specialty. So you could click on that and see what their specialty was. Although this gives you a code, so you'd have to look.
Hover over it.
Okay.
I thought we
Yeah,
had
there you go, vascular
where
surgeon.
It'll say vascular surgeon.
You're right.
Yeah, so I think sometimes that hover feature will work and it will show you the concept.
Yeah, the hover feature is pretty great in a lot of HERON. So if you hover over any of these folders, it will give you an explanation of the folders. So what's in it? Sorry, I was kind of moving my mouse around too fast, but this explains the diagnoses are organized by ICD-9 and ICD-10 codes. So the hover feature is definitely one of my favorites. So if we wanted to add,
So, sorry.
Go ahead.
So the timeline, it's a great tool. It's not one that you're necessarily going to be able to analyze a bunch of data with. I mean, you'll go blind doing that. And it would take forever to like scroll through each one of those patients. But I use it sometimes when I'm developing a complex query of where I've got some things are in the same financial encounter, some things are not. I'll run my query, get my numbers, and then sometimes I run the timeline so I can visually do a couple checks. Okay, this patient had this and this happened with it. Make sure that the things that I want to happen at the same time are aligned here. So kind of a way to sometimes check my search to make sure, visually check it that, okay, this is what I expect it to be.
all right, so does anyone have questions? I feel like we've done a lot of things, but are you guys all following along and running queries?
I just had the one that you gave me, I thought was great, was about naming the queries.
Uh-huh.
I was good at it.
Oh, just run query and name it?
Yeah, so that you name it and it doesn't look like that, and then you're like, what in the heck was I searching?
Yeah, it's
That was good advice.
Thank you. Yeah, I think it's a lot better to give them real names. I'm just demoing, and so I'm just hitting run a lot, and I don't want to give it a real name every single time, but I do encourage all of our users, if you're running things, give it a name so that you can look back at your previous queries and know what the query is about. Because if you just let it auto name it, I mean, no one really knows what the name's, it's not descriptive. And I do recommend typically if you add something to it, this time I might say atherosclerosis with hospital LOS. So I kind of say what I added each time, so it's really clear like what I added. And that way you can also look back at the numbers to see how it changed over time. I wanted to show how to search for medications and lab values. So I don't know if there's a specific medication that somebody's interested in looking at, and I can demo that. Otherwise, I can look for anything. Is there any medicine that anyone wants to look at, or? No? Okay.
Yeah, we were looking at time of admission for like the side assessment piece when they actually get the Rocephin antibiotic.
Okay.
That'd be helpful if we were having trouble finding antibiotic codes when we were in our group.
Yeah, so Rocephin, R-O-C-E-F.
E-P-H-I-N.
Oh, E-P-H-I-N. And then you'll want, so whenever you do the find and search by names, you can type in the medicine name, and then you can change any category, and you're going to only want to search the medication folder. If you search all of HERON, it's just going to take longer. It's going to make you frustrated. It's going to make the computer frustrated. So just choose medications and then type in your name and hit find. And then, so it returns about, 10, 15 results, and you probably don't want to drag over every single one of these. So instead, what I recommend doing is, actually, there's only one that really has a lot of patients. So if you look at all the results that we just got, most of them don't have any patients or facts. So that means there's no real point in pulling them over. This bottom one and this Rocephin IJ are the only ones that really have patients and facts, but let me show you the typical technique. So you'll want to hover over it, and then if you see there's brackets here, so it says AM000 and then AM114 and then AM117, and obviously there's words after it, but I find it easiest to just remember what's inside those brackets. So AM117, and then we'll look in that subtriaxone injection. And so we'll go back, AM117. So navigate terms, we're gonna look in the medication folder, and then you'll see here's all your letters and numbers. So we'll go down to antimicrobials, and then I guess it's in this 114 folder. And then here's 117, cephalosporin 3rd generation. And then I think it was what is it? Was that it? Oh, here it is. Thank you. Injection, I think it was. And then here's your Rocephins. So sometimes, this was kind of a bad example. Oftentimes when you navigate back to here, then all the Rocephins might be in a higher level folder. Here they're still all separate, so it didn't really help you out. But you might actually decide that you want the Rocephins and the ceftriaxone, and you pull it over from a higher level folder. Otherwise, just come down here and we'll find the Rocephins. And like I said, only pull over the ones with patients. So we'll pull over this one that has 40 patients, and we'll pull over this one that has 88 patients. You can click Run Query, and then we'll see how many patients in total have it, because it's 128 patients. So that's kind of how I search for meds. Now, did you want me to put together something else for you, or is that good? Do you kind of know how to build it on top of that? You can go from there. Now, are there any lab tests that these patients might have?
Yeah, that's the other one. We found too, it's just people bill it in like 8 different ways, so we have trouble finding it. Most consistent would be like they get a cell count with differential. I'm trying to go through all the fluid studies.
Cell count? Okay, so again, the things that I use the search by names for, I use it for the meds and the labs and the flow sheets and things like that. That is typically how I go and find any of those things. The diagnoses, I don't typically use the search by names just because it will return lists that the computer can't even load. So that's where I typically go to Google and then go back through the tree, because Google has the ICD-9 and ICD-10 codes, just so you guys have at least my techniques for searching. So we can do cell count, and then again, you're going to want to switch this category to be the lab tests, KUH hierarchy, and hit find. So I've got the cerebrospinal fluid cell count. Are any of these what you're looking for, or no? This one? Oh, the third one, miscellaneous fluid count? Is that kind of what you're interested in, like these fluid eosinophils, or is that?
Yeah, we found out we did kind of a mini chart audit and where we reporting it differently in the lab tabs.
In the lab tabs, everyone was reporting it?
We found it was really not the same way, which
is there, so, any way that they're recording it, we should be able to find it though in here. So if there's a couple, sometimes, you might have to search a couple of different things. Is it like the lymphocytes that you're looking at, or no?
Usually comes out with, really, I guess the neutrophils is what's the big one.
Neutrophils?
Segment. I'm trying to go to the fluid segment and once open that up.
Yeah, because there's also that, so there were the if you look for neutrophils, you can find them in the hematology folder under blood counts. Maybe that's what you're looking for. So again, I hover over it to know what folder it's in. If you're a clinician, you might already know what folder to look in, but if you don't know, that's how I find it. So we can go back to the lab test folder and then go to, what was it? Hematology. And then cell counts, blood counts. And you can use Control F in here and then just do neutrophil, just like you would in anything else. So you've got absolute band neutrophils, segmented neutrophils. Any of those what you're interested in?
Actually, yeah, I'll connect it.
So then you,
Under heme is probably my favorite.
or you could look at the other ones that we were looking at with the cell counts if you want to. It makes it a little bit, uh-oh, my computer's frozen. So let's see. So we can go over how to request data if you guys want. So go to the HERON, on the HERON homepage, there is, under investigator requests, this is where investigators can sponsor residents, students, staff, or they can also request the data. Like Russ said, we are changing this process, so in the next 6 months or so, anyone will be able to request the data, but the faculty member will have to go in and approve the request. So currently, the process is that the faculty member clicks on the HERON data request. They can add anyone that should get access to the data. So I'm going to go ahead and add myself and just say add. They can choose as many people as need access to the data and then say done choosing people. It will pull up this form. And in this form, they'll give the title of their research, the purpose of the request. They'll give information about the request, how they plan to use the data, if it's identified or not. So if you needed those real dates, you needed the MRNs to go back into the medical record, you'll want to make sure to choose yes. And then you'll say if it's research or quality improvement. If you choose research, you're going to need to provide the IRB number. It must be IRB approved. You'll say if it's retrospective or not, and then you'll attach the IRB protocol. If it's QI, you'll need to attach the QI letter of determination, what's the problem you're addressing, what data is needed, and things like that. And then if you choose that it's not identified data, you don't need to do any of that. There's no extra approvals needed for de-identified data. And then you'll just put in your saved search name. So if we wanted the data, oh, my HERON is frozen. That's why it came to here. Oh, just reload it. Is that my problem? Unknown. Maybe I just need to log out or something. Sometimes you do have to log out and log back in of HERON. We'll see if I can get back in. Saved search name. So if we finish that search and we called it atherosclerosis, that's going to tell me when I go to pull the data what query you want pulled. So I will pull all those patients that came up in that query, and then I will pull any data elements that you had in the query. And I'll go through again just to make sure you guys know exactly how to get like your shopping cart finalized and all of that. I'll show you that in a minute. And then are you requesting a data set containing physician or flow sheet notes, yes or no? And then, like I said, everyone that needs access to the data needs to be listed here. So that's what the faculty member will be submitting, and soon anyone can submit.
Can you tell us a bit, how detailed is it? As a coordinator, like, I don't have one single research project. I have like 8 residents that are doing various, so does it matter what's really in there, or?
Well, for every project, you need a new HERON data request.
Okay. Was this the sponsorship?
No, this is the data request. This is the data request. Yep, so for every project, you'll need a new data request. And it doesn't have to be a super detailed description, but at least enough that we kind of know, like, what are you looking at? What's your inclusion criteria? What's your exclusion criteria? Kind of what is your goal of studying this? It doesn't need to be, we give you a block to write it in, so we're not expecting, a 15-page protocol, but you can upload your document, your protocol here. Okay. So yeah, that's working. Should I show the data, or should I wait?
Let's see if there's questions first.
Okay.
Does anybody have, we've gone to, Mars on your time.
Can you show us what the shared folder's for?
Yeah, that's a great question. So if I am, say this query for Cephin IJ, I can add that to the shared folder, so I can just make a new folder within it. I just ask that you don't just drop your queries into it, because then it just starts to look really messy. So just right click on the shared folder. You can click new folder. I'm going to try to get it up at the top. and say fishing trip. I'm going to put A's at the front so that it hopefully will be at the top. Yes, there it is. So then what you do is I can drag this query into this AAAA fishing trip folder. And now you guys can all open up that query. So you can go into the shared folder now, open up this AAAA fishing trip, and then you'll see this Rosefin IJ. You can click on it and again drag it up to the query name and then it will populate. So that's what the shared folder is for. So if you have residents who might be making queries and they want to share it either with you or with the faculty member or vice versa, if you made the query and you're like, hey, I want you to take a look at this, you can make a folder within the shared folder. Again, I use this resize workspace all the time. There's a lot in here. So just, you know, make a folder for your project. Then you can use the Control F to get to it more quickly. So, well, here's one that I've worked on, this POP trial. You can just Control F to find it more quickly, because otherwise you'll be sorting, so filtering for a long time.
Quite a few folders in there.
Yep, go ahead.
So on the medications, I can see that you sort by the drug class. Can you show us, walk us through that?
So the drug, like you want, if you can sort, so you can search by a name, or you can just go into the medication folder and look at like these like antihistamines.
So if there was a question about milligrams of a specific medication per patient weight, can you pull it out of here, or would it be a query for you?
So you'd have to query, you'd have to get the raw data, and then you could get the dose with the raw data, and I guess you could get the, you know, patient's weight as well. I'm not sure if it will be listed, or I guess if I'm not sure if the dose will be listed as per kilogram, like, or if it will be listed as like 240 milligrams, and then you might have to calculate what was that per weight.
There is
So Ellen is on the phone. Ask her if she's got other questions about that.
Okay, Ellen, Amy is asking if you have other questions about the medication dosages.
I was trying to query all of the medications for opiates.
Okay.
And I couldn't find a way that I could just get opiates. And then it would be under analgesics from a class.
And then there's opioid analgesics?
Yeah.
Is that what you're looking for?
And can I find out how many times they were administered to patients?
How many times it was administered?
How many times it was administered to patients? You would have to get the raw data for that.
Okay.
So that would be a query to you.
Yep, so a query, yep, you would build your query in here, and then the faculty member for now would go in and submit this data request like we just went over.
Okay.
And then you could get the data, and then you could analyze it to say how many times was it administered. And we do have the information from the medication administration record, so you can see how many times it was given. So you could definitely look at that.
And could I find out how many times it was given for a PRN order versus ordered every 4 hours?
Well, if it's on the medication administration record, I imagine that nurses document every single time it was given, so I think you should be able to find it regardless of if it's PRN or every 4 hours, as long as it was documented on the medication administration record. So if it's not being done, go ahead.
It would be there. It would be there. I was just trying to figure out PRN versus not, but that's okay.
Oh, you mean you only want it for PRN meds? Is that what you're saying?
Yeah.
So you can look at this frequency, these modifiers.
Oh, I never did find that. Can you scroll up to show me where that's at?
Where the modifiers? They're underneath every single folder. So under analgesics, there's modifiers. Then if I was looking specifically at opioids, we'll find the modifiers in here. And I think that there's PRN inpatient order. So you could pull over just this PRN inpatient. So this is, okay, so here's how you use modifiers. Yeah. So if you are looking for only PRN inpatient orders, you'll pull this over from the specific folder that you want. So you don't want to just pull over any PRN inpatient orders from higher up, you want to pull it over from underneath the opioid analgesics specifically, if that's what we're looking at. So you'll pull over the PRN inpatient order, and then you could run query and see how many of these. So we already know that 365,000 patients have been prescribed opioid analgesics, but pulling over this modifier will say how many of those were PRN inpatient orders.
Okay, very
Medications
good.
have a lot of modifiers with them. I mean, there's many different ways you can look at the medication. As a result, that query was pretty quick, but if you've got a lot of medications with a lot of modifiers, if you're doing a complex search, can sometimes slow it down. So in citations, a lot of medication data.
Should we take a break?
Sure.
And then
Thank you.
continue querying and show the data. Oh, do you have a question?
Yes, so if you do a
No,
query
just thank you.
and a prospective study
Mm-hmm.
that shows 1,000 people meet the criteria that you're reading,
Yeah.
then the only way to get those data would be to submit something that says I already have IRB approval to do this study. So there might be 1,000 people listed who have data, but there might be 100 or 50 who agree to be contacted to participate in the study. Is that right?
You're saying like through the Frontiers registry or something?
Yeah, so how do we run it through to see of those 1,000 people who meet the criteria?
How many are in Frontiers?
How many of them have agreed to participate in?
Sure. So if we have, let me see if I can pull up that PRN is too big to use. Let me just try to find a little bit smaller of one. Is this one too small? Is that okay? No, it's too small. Let me find my last one. Okay. So for this atherosclerosis example, if this is my patient population, I'm going to go ahead and add a new group. And sorry, I have to resize all of these. Right-click again and refresh them to close them. I'll go into demographics. And so in here, there's a Frontiers Research Participant Registry. And we can open this up and say, pull over OK to contact into group 4. And then in group 5, we'll want to add another group. So you can keep adding new groups. So group 5, we will want to exclude anyone who's passed away. And again, I pull over the deceased folder and then the deceased per SSA and click on exclude. And then I can click run. And so these will now be so now these are my patients and Frontiers for my study. And again, if that number is too small, like if you're doing something very specific and that is too small, but if you're a clinician in a department, you can always get the patients who are in your department, and we find the departments under visit details, and there's clinical service department. So we could look for, you know, I guess you guys are urologists over there, so we could look at outpatient visits for urology, and we could pull over urology. We could also pull over, you know, whatever department you're in, and then we could find you know, how many patients just are in your clinics, if that would be helpful. We do typically say to start with the Frontiers patients just because they've already said it's okay to contact them, but we understand that realistically sometimes your numbers just drop so much. Like we saw here, we're down to 121 patients who are in Frontiers and who are still living. So, you know, the reality is just sometimes it's too small, but sometimes it's large enough.
So it's under demographics and then Frontiers.
Yep, and then
how do you add groups? Let's say I have 5 groups.
Yep, it's down here. It says new group. Can you see that?
Yep.
Okay, yep, perfect. I'm thinking maybe we'll stop and take a 15-minute break, and then we'll come back and I'll show you what the data looks like, and we can do more example queries and answer any questions you guys have. And then we'll also let you guys just run some queries, and we can walk around and answer, you know, really help you a little bit more specifically with your own individual queries. Does that sound good? Perfect. the training data I have is looking at tonsillectomy and height and weight values. So I'll show you, I think we kind of mentioned making a shopping cart, and I'll just kind of briefly show you how to do that. So I was just looking at the CPT code for tonsillectomy so that I could build it, and it looks like it's 42820 and 42821. So in HERON, you can go to find, and we can use the search by codes and select the coding system and choose CPT. And I can just put the CPT code right in there, and then it finds it. So I can go ahead and clear out my query, and then I can pull over the CPT code. It was also 42821. I can hit find, and then I can pull that over as well. So if I run this, I get 4,088 patients. And if I'm interested in looking at their vital signs, if I go to visit vitals and I pull over BMI and say no value, we can see how many of the patients have a BMI.
Which will be less than 4,000 because some of those billing codes go way back before Epic was live.
That's my hope, is that it's less than 4,000.
Less than 4,000.
That's my hope.
Your hope.
This is really slow. It's thinking really hard.
You're going to do a data set?
Yeah, I've already got data. Yeah. I just wanted to show how to build the shopping cart, but this isn't displaying very quickly. Okay, so 2,594. So it's, what were we at before?
4,000.
4,000 something. So it did cut it way down, but if I don't want to cut it down, if I want to include those 4,000, you know, if I want my population, my inclusion criteria was that they had tonsillectomy, and then I want to get their BMI data, but I don't necessarily want to exclude them if they don't have it. This is where we build up this shopping cart of all of our extra variables. So to get this number back to 4,000, you'll want to open up demographics and pull over gender, because everyone has a gender on file. So now when it goes to do the and, it will say and they have a BMI or they have gender. And since everyone has a gender, then they'll be included. So this number should automatically now go back up to 4,000. So we always say to make do your inclusion criteria and your exclusion criteria in the first several groups, and then have your last group be your shopping cart. And then fill that up with the medications that you want to know if they were on. You know, if you wanted to know if they had diabetes or not, you'll want to put that into your shopping cart. Now we're back to the 4,088. So this is really just a trick, but you'll need to do that before you request data. So I wanted to make sure that everyone knew how to get your shopping cart. So if I were to finish filling this up, if I was also interested in the vitals, height, again, I'm just going to say no value. I just want to know what their height was. I don't care, you know, that it was less than or greater than a certain amount. And then also their weight. So I can.
How are you doing that again? I'm not quite.
How am I doing?
Choosing things from the list where you just want the values, but they're not included criteria.
Yeah, so I'm putting those into my shopping cart here in group 2. Do you see this group 2? You see how I have a gender here? Yeah. So I've added gender to make my shopping cart, and then I went into visit vitals. That was underneath visit details. So I opened up the visit details, then visit vitals. Now I'm going to pull over weight, and it asks me for a value. So if it was part of my inclusion criteria that they had to have a weight less than so many, I think this is in ounces, so I'm not sure how many ounces is normal, but less than a certain number of ounces, you could put in less than, you know, 3,000.
How are you specifying that it's the shopping cart?
It's the shopping cart because I put in gender. That was what brought it back up. Do you remember the first query that I ran with just the tonsillectomy was just the tonsillectomy and body mass was 2,590. Sorry, I need to go back one more. Just the tonsillectomy is 4,088. So that's what I want my cohort to be, these 4,088 patients. And then when I added in the body mass index, it dropped to 594. In order to bring that number back up to 4,000, I had to add in gender. So when I added in gender, that turned it back to 4,088. So that gender really is saying that it's the shopping cart and letting me just keep adding variables that I'm interested in studying, but that don't necessarily exclude patients for not having it. Does that make some sense?
It's just because, so, because that's, because the second column, you can have either one of the BMI along with gender, right? And everyone's the gender. So it's every one of that 4,088 will satisfy that rest of it.
So what you usually see is you'll typically have a query that defines your population. It might be, what do you think, 3 to 5 or 6 conjunctions?
Mm-hmm. 3.
Let's say 3 typically. And then oftentimes somebody will have another, and one of those columns that where people oftentimes have their criteria will be an exclude, it'll be exclusion criteria. And then what we're saying is that defines your population, which in her example was just one column. She just said, I'm going to take a simple example where the inclusion criteria is either type of tonsillectomy. But she's now showing you to build a shopping cart to say what data elements do I want. She puts gender in because everybody's got gender, and then she throws in there all the other things you want because they're going to be ordered. So it's, if we were fancy, we change the user interface and say shopping cart, but because we don't know how big people's conjunctions are going to be, it's just an easy way for us to tell you, go ahead and load up all the things you want in the last group.
Yep. Does that make?
Yeah, so it has to be something like everybody has an age.
Yeah. And that's why I just.
Some variable that everybody has. If everybody doesn't have diabetes.
Exactly.
That can't be in your shopping cart.
Well, you can put diabetes in your shopping cart, so then you get the data on diabetes, but you have to put, just in addition to the diabetes, you have to put something that everyone has. So that's kind of the whole point of the shopping cart, is for things that some people may have and some people may not have. But then you want to put something that everyone has to encompass all of them. So I just always say gender because it's a small folder, it's a female or male, everyone has it. So does that make sense? So
Let me back up just a bit.
Yeah.
So if you have a cohort and you want everybody in that cohort, like for her tonsillectomy, she doesn't care if everybody has it, she just wants the BMI if they happen to be with one of the patients. But if you do want every one of the patients to have that BMI, that does have to be a separate group.
yeah. Yeah, that's a great point. So if I also put in, I could put in height and weight here, and then when it comes up with the value, I can just say no value, and then I can put weight, and I can say no value, just because I'm not using that as an inclusion criteria. I can run this, and then I can just save this tonsillectomy. So if you were to then send me this query, what I would do is I would save those patient numbers in the background, and then I would pull all 4,000 of those patients, and I would pull all of the data on these terms listed in the query. So if it's not listed in your query, you won't get data about it. So if you wanted to know about their hemoglobin A1C, but you didn't put it actually in this query, you wouldn't get any of their hemoglobin A1C values. The elements have to be in the query in order for you to get data. So if I go into REDCap, that's where we actually do, we went over how to request the data before the break. So, you know, once you request the data and it gets approved, we will deliver it in REDCap.
Now they will get kind of for free some basic patient demographics.
Yep, so in REDCap, this is all just training data. It was already de-identified data, and then I've shifted it even further. So it's just really made up data. So this, I clicked on record status dashboard. That shows you all of your patients, and then these are the forms for the study. So these are built based on what you put into your query. So in my query, I had procedures and visit details. I didn't have any other things. Patient, like Russ was saying, you're going to get this for free. So if I click on this first one, you'll see you get the patient number. If you ask for identified data, you'll also get the MRN. You'll get their vital status, so living or deceased, birth date, death date, age, sex, language, race, marital status, and religion. The one that we don't give is ethnicity. So if you need ethnicity, you do have to pull that over separate. Then if I go down here to visit details, I'm going to skip the procedure form. I'm just going to go to visit details real quick. So these are the things that I put into the visit details. So I also had included age at visit, so we get data on that. And then here's the height. So there's a count of how many times height was recorded in the medical record. So for this patient, it was recorded 15 times. You'll get the first date, the last date, and then the last value. We've also got that for weight. And then you'll see the same thing if I scroll up and go back to the procedure form. You'll see the same thing on the procedure form. So some of them are blank, and it just means that it was not coded as that CPT code. Just means they didn't have this CPT code, but if I keep scrolling down, I'll see the one that now this patient had it coded under tonsillectomy and adenoidectomy younger than age 12. And again, you get the count, the dates, and then the code. So that's the summary of the data, but we'll also give you the raw data. So if you didn't just want the count of 15 for the height and weight and the last value, you can go into the file repository. It's over here on the left-hand side of the screen.
How many people have never used RedCap? Okay. So if you've never used RedCap, you all have TMC logins. You can access it. It has built-in training videos, but it's very widely used around the globe. So it's a really good data management tool. And those RedCap summary things she's showing you, what's powerful about that is RedCap has like built-in data quality checks and visualizations. So you kind of can use some basic RedCap functionality out of the gate without having to deal with raw data. But it's now punchline, you got access to your raw data.
Yep, so you've got a zip folder, and you can download this. And we can open it up, and you'll have 4 CSV files. So you'll have a data view table, which has all the data in it, patient view, code info, and variables. So I'll start with the patient view.
It comes to your RedCap automatically. Can you test it, or how does it come to RedCap?
Yeah, it will come to a RedCap. It's not immediate. It takes about 2 weeks. So about a week for the request to be approved, and then about a week for us to pull it. And I will send you an email and I'll upload it into RedCap. So it's not just totally an automatic.
Sometimes it's quicker. But the process will get better. But in general, it takes sometimes we have a laggard person approving things.
Yeah.
Or Mara's on vacation. So.
It may very well be faster than 2 weeks, but I don't want to get anyone's hopes up. So we say within 2 weeks we should have it to you. But we do try to get it. And if you tell me that you need it faster, we'll try to push it through and get you the data faster. So this is the patient view table. And so this is basically what you saw in that patient form. It's their basic demographics. You have 1 row per patient. So you've got their patient. So this is 1 patient right here. So that's kind of what the patient view looks like. If you requested MRNs, you would find that in the patient view table. Now we have the data view table. And so then this is going to be multiple rows per patient. It's 1 row per fact. So you'll see here's the patient number here. And these are all of the rows just on that patient. So you can see the variable is in this column. And so if I scroll down, we can look at the heights. I'm just going to highlight. These are the 3 rows for height data for this patient. So this is where you would see there would be 1 patient in here who might have 15, it would link up with the RedCap project. So where the count was 15, here you would see 15 rows. But for this specific case, there's 3 rows of height for this patient. And this is the value. It's in the NVAL column. And so you get the value for every single one of their heights. And we have the start date and the end date that was recorded. So if it was a length of stay, you would see a start date for the length of stay and an end date for the length of stay. So that's kind of what the raw data looks like. You do have to obviously clean this up if you want to do, before you do statistical analysis, you're going to have to clean it up to what you're looking at. And then we do have these variable and code info tables. The variable table, shows you what variables are in your query and the variable name, and then has an index, which also links to the data view. And then the code table shows is all of the codes underneath of for each variable. So you'll see here for this variable path, 0 to 9 years of age, and the variable 0 to 9 years old at visit, there are many codes underneath that. So here are all the codes associated with that variable. Yeah.
I downloaded mine off of RedCap, but I went a different way, and it came like all in one big spreadsheet. So it's your data exports, reports, and stats.
Yeah, so that data exports, reports, and stats. If you click here, you can export the data, and you can export all of the data. But the thing is, you're exporting the RedCap data, so you're exporting the summary of the data. You're not, versus the raw data that's uploaded in the file repository is actually every single one of those height values. If you download this export data from RedCap, you're just getting the summary that there's 15. Yeah.
So
if that's,
you have, that may be sufficient.
Yeah, if that's.
So if you say, I just want to know the last height, I want to know, have they ever had this code? That's why the RedCap thing is really powerful, because you can use all those built-in features of RedCap. But if you're in trickier world where it's like, I want to know the lab value before this or this after this, then you're going to need to start writing some SQL to clean up your data. You know, the other component of what she showed you about those variable views and the code views, when you ask for all ICD-9 codes of a certain class, like ICD-9 250 for the broad class of diabetes, if you've got all that data, then you want to say, well, I want to treat the people with complications slightly differently. Then you may want to be in that raw data world where you're kind of splitting your data into chunks. So we find, and I actually teach a class in the fall on HERON to students, we take HERON, you really learn how to use it, and then you learn a little bit of SQL, structured query language. You can learn how to temporally process your data, you know, and pretty much divide up your data however you want to then convert it into whatever final analytics set you want. So for some things, you're totally right. It could be, and we've had students do some pretty powerful projects just using the summary RedCap data, because they may just want to know just basic information about a breast cancer population and what types of comorbidities are there. But if you're getting into a space where you want to say, I'm interested in quadriplegic patients, and after their admission, what happens to their metabolism or something, and I want to track it like in 6-month intervals. Well, then you need to start rolling up your sleeves and writing some code, or you need to, Maren will tell you we have a fee-for-service rate, and we can do that for you, or you can work with somebody else to do that. So that's kind of how it works. Does that make sense? So you get both, you know, if you want to, because essentially all healthcare data is very temporal. And so sometimes the summary's fine, but for many analyses, you need to get into your raw data. And I find that's a very big translational gap. A lot of people really learn their scientific domain, and then they may have learned some basic statistical testing and learn how to program SAS or R, where they know how to run those routines. But this goal of how do I deal with the messiness of healthcare data and then pivot it around to make an analytic file takes some time and a little creativity.
Mm-hmm. Yeah, and I'm encouraging Derek. I've encouraged him a lot, and I've encouraged all of our users to, you know, if you do have those, you know, those questions, to use SQL. We've got training videos, or I'm happy to meet with you because I'm encouraging everyone. I am willing to sit down and try to help get you started. If you click on this Understanding HERON Data, there are videos on how to understand the RedCap project, like I just explained. It's the same RedCap project, and then how to understand the raw data, how to download it, how to put it into SQLite, and then how to do some basic SQLite commands.
In the manual, some basic SQLite.
And we've got it in the manual as well. So if you download the HERON manual, this is actually I would prefer to do this than watching the videos. So if you go down, you can click on Receiving Data and scroll down. It goes over the RedCap project again. It goes over the raw data, and this explains what is in those tables. So I just I skimmed over it, but each one of those columns means something. So what does that mean, and how do they link together? This goes over and explains it. So I encourage everyone to do that rather than going back and doing retrospective chart reviews, just because, I mean, it's time consuming. It depends. If there's, you know, less than 100 patients, you might be better off to go do the retrospective chart review. But if it's over, you know, 300 patients, then doing the SQL helps.
Here probably bring up just in terms of The other benefit of you getting used to writing software code like SQL or even doing it in R in a consistent way is there's a big buzzword in science called reproducibility, and just how bad it is for biomedical science and how unreproducible many people's studies are. So you think about the work you go through where we have people get data out of HERON and then they manage it in spreadsheets and then they kind of, oh crap, what did I do yesterday? Mm-hmm. So when you do work where you kind of get a data set in Excel and then you mush it around, you're playing with fire that you may forget. Why did I do that? Was I drunk that week when I made that change or decision? Whereas if you always keep your raw data and you pull it down and you run your commands against it in a repeatable way, you should be able to pick it up and run it again next month. Or, you graduate and you give it to your new fellow and she takes it and runs with it. So that's kind of best practice that we're, I think, increasingly through the CTSA Frontiers program and national efforts, there's going to be increased focus on giving people tools to make their research more reproducible. The other comment we make about SQL, people nowadays, there's newer database technologies, but SQL has been around a long time, and still to this day, almost every business system you interact with is kind of a link with a Franca. SQLite is a totally free little database thing that you can download on your desktop or anything really easy. It has limitations. So if you start managing big data, or like remember when we were building that shopping cart, it's kind of like you get all excited at the buffet, you take all you want, but then you got to eat all you take. If you load up your shopping cart with a lot of stuff that happens all the time, like you want every blood pressure from a 20-day length of stay, you're going to get a lot of data. And SQLite can kind of it's not that big of an engine. So if you really got big, you may find you would want to take those CSV files and load them into a bigger database like MySQL, possibly Access is a little bigger than SQLite or SQL Server. So there are cases where you might want to move that data to a more robust database engine. And I would say the other thing that's coming over the next year is if you have a project where you're thinking about doing data mining and knowledge discovery, which we do in our group under Dr. May Liu, where you don't want to necessarily take all the data, but you'd like to apply some knowledge discovery algorithms to predict like when do people get diabetes associated kidney disease, then you don't want to copy all of HERON. You would just like to run your algorithms on the raw data. We're working as part of our refunded CTSA to build out a new analytics server where you could get a seat on the server and then run your code against the backend database. And that way, you don't have to get the data. You can just analyze it on a very big, powerful machine yourself. So stay tuned. If you get in that space and you're doing more advanced work, we've had a number of people who start small and then they get big, and it's happened with some of our class students where they really get big. They're like, oh, I want to do this on every diabetic. And you're like, whoa, 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 whoa. For this class, we're teaching just SQLite, rein it into a smaller population. But then if they want to go big, they either work with us on a bigger database engine, or we will hopefully over the next year get our analytics environment set up so people could just run it on the main box. The other thing, if you're curious, is this okay to plug this now? The other thing that's coming soon that's available is we are part of a national consortium called the CoreNet, and our specific network is called the Greater Plains Collaborative. So when you look at HERON, imagine that you want to do this and you'd like to generalize your research to another campus. So we have all these partners running down the middle of the country right now that run the same infrastructure and can extract data the same way. So if you were studying atherosclerosis, cerebral vascular disease for certain admissions, and you said, I've run this at KU, basically at ultra low cost with Maren support and the team support, and now I want to do it at Missouri, Indiana, and Milwaukee, you'll need to have some funding, but you could basically get equivalent extracts from those places merged into a single merged together so you could do that analysis across multiple institutions. The other thing in this that is very exciting is, oh, you're plugging it all. The HERON interface, this isn't quite ready yet, but we have a thing called Shrine. And our mascot, in this case, because it's the hosted in Wisconsin, is the cow covered in snow, the mascot of the state of Wisconsin. And so Snow Shrine allows you to run a HERON query against data here and at those other partner institutions. And we're the first people doing this type of distributed analysis query that includes the cancer registry data. at a couple sites. That's pretty powerful. You need to look at breast cancer population exposed to cardiotoxic drugs and then look for cardiac events. And you could look at that and start exploring that across several sites. There's a request form to get access to Shrine and touch base with Maren and Tamara about how it's evolving. So that's exciting. And then the final exciting thing is grouse, another bird. So everybody know about the grouse? Big bird. So grouse, we use the same grouse, the spiky grouse is our mascot here. The white guy. Oh, he's being handsome. Okay. So anyway, grouse, part of this PCORI contract was EMR data is really great, right? Hospital data is really great. But for the most part, people don't receive all their care at a tertiary academic medical center. So we have very rich data when you're here for your surgery, your trauma, your medical oncology treatment. But then you leave and you go back home. And back home could be in Kansas City, and you see a primary care provider who's not part of the KU Health System. Because if you look at KU Health System, it's predominantly staffed with specialists, not with primary care. But grouse, we've actually bought all the Medicare claims for 5 years and 1 year of Medicaid, provide another year of Medicaid for the entire state. So you have to work with us to apply to reuse this data from CMS, but we haven't linked up. So you could look at data on patients at KU and say, I want to look at the breast cancer people at KU, and I want to look and see what happened before they got breast cancer. And we can look and see, did that Medicare population, had they had primary care treatment before? And then after their breast cancer treatment, how are they doing afterwards? And you could also look at things like Part D drug benefits, where they get their prescription filled and reimbursed by Medicare. We have that type of data available. And we also have that type of data available on the Medicaid population. So if you're working on things and you're thinking you're interested potentially in that claims view, contact us about that. The other thing the data could be reused for is maybe you don't care about KU, Milwaukee, Iowa as medical centers. You just want to do an analysis of claims data. And you just want to look at 20 million beneficiaries and know, well, how frequently is vasculitis occurring in the larger population? And what's their drug, what type of drug prescriptions are they getting used for? What's happening in stroke admissions around the Midwest? That's another use of grouse. So yeah, those are kind of new features for what we offer in medical informatics. So that could probably be for an advanced class. We may have some advanced classes coming where we go into greater detail for those types of data.
Yeah, so I think my plan now was if you want me to demo specific queries up here, I can to the class. Otherwise, we can come around and help you build. We always like to leave a little bit of time for some just hands-on searching where if you're struggling to get something to work, we can all come around and help you guys do your searches. So if there's something specific you want me to demo up here, I can. Otherwise, we'll just do some hands-on searching and come and help all of you with any problems you're having.
If there's any classes of data where you want to know more about it, we can.
Yeah, if there was anything we went too fast on, we can repeat it, whatever. Any specific questions?
I have one.
Yeah, thank you.
On the flow sheet, there's a number of different sources. So KU is obvious, ophthalmology is obvious.
Yeah, that's a good one.
What is like
I'll give you the whole story on this one. Okay. So this is really interesting. If you look at our warehouse for Ellen's from nursing, so this is an amazing resource. We actually were one of the first places in the country to reveal all our flow sheet data, and you'll notice over half of the warehouse is flow sheet data. So what you're seeing here is the way flow sheet templates are organized is fairly ad hoc. There's not a national hierarchy like you have for diagnosis codes. So what we do is we bring in the highest level categorization in the flow sheet design at KU. Now, one funny thing to notice is Epic has a model that they say these are model concepts for flow sheet data, like Pulse, I think, is number 8. And so you actually see we still have 335 million facts that use model concepts that Epic defined. But the main flow sheet build has, largely the inpatient has 1.5 billion facts. And then UKP is kind of, if you close that out,
Oh,
and go
sorry.
back to UKP. UKP is kind of some of the newer ambulatory flow sheet build-outs. So the main two buckets I would look at would be KU and UKP. So if she opens up UKP, you'll see some things in here where in a clinic setting, they may be documenting adult cystic fibrosis clinic visits in a fair amount of detail. That's being done in a clinic setting. And then what you'll see here is just that's what the concepts are. There's probably a couple things here, and this is good that we actually I gave a talk at our spring meeting, and we found, I think, what was about 15% of all data requests have used flow sheet info, and the same thing with queries. So, there's a lot of good data in here. I'll close that one out, and then let's go to KU. So most of the flow sheets start with the letter KU, and what you're seeing here is, this number is the name of the template that assault and abuse screen. And then,
I don't.
you up.
Oh, did you touch? Is that why this came up? Are you touching the screen wrap?
Yeah, you can touch it.
Okay.
Yeah, I guess you could control it.
Okay, well, let me not do that. Okay, so open up the abuse sexual assault screen.
I think you could.
Abuse.
I don't want to break it.
Okay.
Okay, so open it up again. So then what you're seeing here, I believe, is that they only have one grouper within that called abuse sexual assault. And then those have flow sheet measures that get asked to the patient. So I think if you hover over number 2 here.
This one? I can't see what you're doing.
Open that up. You'll see here, this is a specific flow sheet measure. Have you ever been touched in a way that you didn't like? And the answers are yes, no, too young, and unable to assess. So yeah, that's a great question, because what you're seeing here is what's different about flow sheets is these atomic measures have responses which can be numeric or categorical or free text, and we let you see the discrete categorical responses. In other cases, the numbers will act like a number, and then newly, we actually de-identify any free text observations as well. But that fact, that atomic flow sheet measure could live on multiple templates and multiple groups. So you could have some measures like pulse that may live on many different flow sheet templates, while other ones maybe only live on one. So for example, she could go up to Find and search the flow sheets for touch in any way or something. Did I say that right? Touched in a way, yeah. Let's see what's.
Was it touched? Oh yeah.
Yeah, touched was it. So see here, have you ever been touched in a way you don't like? If you hover on that, you'll see that lives on the abuse sexual assault screen template, and then go to the next one. It also lives on the pediatric patient profile template, so they're reusing that concept in a couple different flow sheets. And then it's also living in the KU IP, kind of the main KU inpatient build in the build out there. And then it's showing here there's a bunch of other things like, fetal position, jump when touched. With flow sheet data, there's a lot of data and there's a lot of concepts. So you'll notice too how we show you how many facts there are, because a lot of times you'll have some facts where there's never been observed, been observed very rarely. So us showing you that's very important, because you don't want to get excited that something is wildly documented and then you find out they've never done this. They built it out of their flow sheet build, but no one ever does it.
Like this fetal position doesn't have any facts or patients associated with it.
But no one's ever documented that. So go back up to navigate terms, because I think what would be interesting to people, do we have any people from health professions here? And you're from what area?
Dietetics, nutrition.
And you're from? Yeah. So if you go into KU and we go down to like KUIP, I'll show you. This KUIP is kind of a general bucket of a lot of inpatient documentation. And for example, in here, as you go down to KU again, you'll see things like, for other people, speech, language, SLP. Here's a lot of assessments happening in speech and language, for example, that are living in the flow sheet that could be very cool. I don't know, could be really cool about what was the patient's goals for speech and language that you could do an analysis on. So those are some examples of some things where there's a lot of really rich data in these flow sheets. I have done a comparison because Milwaukee loaded it, and KU Health System, to me, built out a much more rich flow sheet view than many other institutions. We can debate whether we see some documentation overload that's good or bad. But some examples of some neat data, for example, OT, if you click on temp OT there, that's occupational therapy, go to the adult one. There's some really cool data in here. Like you can see home living situation, and you can see what type of home do people live in, what's the layout, is it 1 level or 2 level, do they have a shower or not? So this world of flow sheets is incredibly rich of what's there. So those are some examples of data that's available for research. There's also, if you go back up, like there's a whole section on pressure ulcer assessment. There's a variety of pain assessments. There's kind of bread and butter pain, but there's also sensation of pain. But the thing you got to watch out for is they may not be documented uniformly across the institution. So whenever you're looking at a lot of this data, you'll see always pay attention to, well, how many accounts are happening? And then run your queries to get a feel for what percent of my patients are having this observed. Same thing goes when you look at that UKP data. You'll see some beautiful data in here, like MOCA testing for cognitive status, but then you'll learn, darn it, they're only doing that in the Parkinson's clinic, So, yeah, is that a good summary?
Yeah, I want to, do you have a question?
I have one more question, and I promise I'll stop. On the pain scales, you've got PIP and CRIES and different pain scales. So as you open those, it's got the individual questions, but I wasn't sure where to see the sum score. So like a Braden scale for skin might have a score of something to 20.
Okay.
And the individual questions are there, but I only want to compare total scores because most of the time they do a total as opposed to the specific questions. Can you show me where that is?
Where's the Braden score?
Just look at pain scores and go to CRIES, C-R-I-E-S. Because I think that any of the scales will be the same way.
Is it in this folder, do you know?
It's in the pain folder.
Oh, in here in the pain folder?
Yeah.
Pain assessment? Is that what you're saying?
Mm-hmm. That's another one.
Okay.
Look at the broader pain and then go to find and type CRIES.
Okay. I wanted to make one comment though before I go away from this, is that when you hover over this and they're coming from different folders, if they have the same number here, number 1620, and the exact same number of facts, it doesn't matter which specific folder you're pulling it over from. Does that make sense? So you can just pull over, like if you're interested in this, have you been touched in any way, you can just pull over this top one. You don't need all 3 of them because you're just going to get duplicate information. And if it's being recorded under multiple places, like, sometimes it's like nursing and physical therapy and occupational therapy, and it's on all of those templates. As long as it's the exact same number of facts and patients, you would just be getting duplicate data. So just be aware of that. So you're saying to search CRIES. Did you already find this or not yet?
There's like 3,200 of them.
Can you hover over it and tell me what folder it's in?
Sure. Well, it's
Yeah, so just hover up the mouse over that.
Yeah.
So it's in KU, okay, so it's in pain number 582.
But now look at that. See how that's only been recorded 13,000 times?
Yeah, because it's only used for certain kinds of patients.
Yeah.
And I've narrowed this to orthopedic.
Shall we?
Yeah.
Do you mind filling out
But
this
you would probably
survey?
find that when you run your query,
Should we just
that
answer
may
this
not
individually?
be being documented on the orthopedic surgery population. You may be, the main pain scores I think you'll find in the system will be at the level of a much higher number of facts.
Right, but if I only want to look at
The CRIES.
babies, little babies.
So I think for the people on the phone, I think we'll move into a hands-on searching, and then we'll answer your CRIES questions specifically, and then we can come and help anyone else who wants to search their own specific things. Before you head out, we do have a closing survey. So just if you wouldn't mind filling that out and give us feedback, that would be great. And for the people on the phone, we'll email that out as well. So thank you for attending.
Yeah.
I'll look with you. Anybody else